The most dangerous symptom of colorectal cancer is not always a dramatic one. It is not always bright blood in the toilet bowl. It is not always a sudden, severe pain in the abdomen. It is not always a stool that looks dramatically wrong in an obvious, unmistakable way. Sometimes, perhaps most of the time in adults over 60, the earliest symptom of colorectal cancer is subtle. It is a change, a shift from what was normal for that specific person. A bowel habit that has been consistent for decades and that has quietly, gradually become different in frequency, in urgency, in character, in the experience of the bowel movement itself. And because the change is gradual, because it does not feel dramatic, because it does not hurt, because it is easy to attribute to diet or to stress or to simply getting older, most people do not mention it to their physician. They live with the change. They adapt around it. And by the time they do present for investigation, because something has become impossible to ignore, the disease that announced itself subtly months or years earlier has had time to advance. This video is about the changes. The specific, documented, clinically validated bowel habit changes that, in adults over 60, persisting for 3 or more weeks, without a clear benign explanation, the research identifies as warranting urgent colorectal investigation. Before we go any further, I must be completely clear. Nothing in this video is a diagnosis. Every bowel habit change I described today has both benign and malignant potential causes. Irritable bowel syndrome, diverticular disease, inflammatory bowel disease, medication side effects, and dietary changes all produce bowel habit changes that can mimic the patterns associated with colorectal cancer. The appropriate response to any persistent bowel habit change in an adult over 60 is not self-diagnosis and not panic. It is prompt medical evaluation. What this video gives you is the knowledge to seek that evaluation, and the specific language to describe what you have been experiencing in clinical terms your physician will take seriously. Why bowel habit change is the earliest language of colorectal cancer. Here is the pathophysiology that explains why bowel habit changes are so often the first thing an adult with colorectal cancer notices, and why those changes are so frequently dismissed. Colorectal cancer arises from the mucosal lining of the colon and rectum, typically through a sequence of genetic and epigenetic changes that begin in a polyp and progress over 5 to 10 years toward malignant transformation. During this prolonged developmental phase, the growing tumor exerts increasingly significant effects on the motility, secretory function, and mechanical capacity of the colon, producing the subtle functional changes that manifest as altered bowel habits. The specific effects depend on tumor location. A tumor in the right colon, the ascending colon and cecum, primarily affects the absorptive function of the colon and produces anemia from occult blood loss, but may produce looser stools, increased frequency, or vague abdominal discomfort. A tumor in the left colon, the descending and sigmoid colon, primarily affects the mechanical transit of formed stool, producing the altered stool caliber, constipation diarrhea alternation, and obstructive symptoms that are more typically associated with the classic colorectal cancer symptom picture. A tumor in the rectum produces the tenesmus, rectal pressure, incomplete evacuation sensation, and altered defecation experience that are among the most specific symptoms of rectal malignancy. What all of these have in common is that they are changes from personal baseline, not absolute abnormalities that are always clinically significant, but deviations from what has been normal for that individual. This is why personal bowel habit awareness, knowing what your own normal is and recognizing when it has changed, is one of the most powerful early detection tools available to adults over 60. The National Health Service in the United Kingdom has built its colorectal cancer awareness campaigns specifically around the concept of change from personal normal, recognizing that the threshold for clinical investigation is not absolute abnormality, but sustained change. The American Cancer Society identifies persistent change in bowel habits as one of the 7 warning signs of colorectal cancer, alongside rectal bleeding, anemia, unexplained weight loss, and abdominal discomfort. Today we are going to explore 5 specific bowel habit change patterns, what each one involves, what it means physiologically, which colorectal pathology it is associated with, what the evidence shows, and how to communicate it to your physician in terms that will prompt appropriate investigation. Leave your age in the comments right now, and tell me honestly, when did you last describe your bowel habits to your physician in any detail? For most adults over 60, the answer is never. That changes today. 5 bowel habit change patterns. Each one a clinically validated warning sign for colorectal pathology in adults over 60. Each one carries both benign and malignant potential explanations, and each one, when persistent and unexplained, warrants medical investigation rather than watchful waiting. For each pattern, I will describe what the change involves, what physiological mechanism produces it in the context of colorectal cancer, what the clinical evidence shows about its significance in adults over 60, and how to communicate it to your physician. We go from 5 to 1, building toward the bowel habit change pattern that is simultaneously the most specific indicator of colorectal cancer in clinical research and the most commonly dismissed by the adults experiencing it. Let's begin. Change pattern number 5. Increased frequency without obvious cause. A persistent increase in the number of bowel movements per day, from a personal baseline of 1 per day to 2 or 3, or from every other day to daily, that has been sustained for 3 or more weeks without a clear explanation such as dietary change, new medication, antibiotic use, or infectious illness. The stools may be of normal consistency or slightly looser. There is no pain, no blood, nothing that seems dramatically wrong. Simply more frequent trips to the bathroom than before. Increased stool frequency without obvious cause can result from tumor-related changes in colonic motility, the rhythmic muscular contractions that move stool through the colon. A tumor in the right or transverse colon can alter the colonic motor pattern by disrupting the myenteric plexus, the network of nerves in the colonic wall that coordinates motility, producing accelerated transit and increased frequency. A tumor producing local inflammation also releases prostaglandins and other inflammatory mediators that increase colonic motility. In the rectum, a tumor can produce increased defecation frequency by stimulating the rectal stretch receptors inappropriately, causing the sensation of rectal fullness that triggers defecation at lower rectal volumes than normal, effectively reducing the rectal reservoir capacity and increasing the frequency of the urge to defecate. In adults over 60, the gut is not typically becoming more active without a reason. The tendency of the aging colon is toward reduced motility. Constipation is far more common than diarrhea as a default age-related bowel change. New onset increased frequency in an adult whose bowel habit has been stable for decades warrants investigation, not assumption of a benign cause. Research published in the British Journal of Cancer found that increased bowel frequency was a presenting symptom in approximately 25% of colorectal cancer cases, with the symptom being more commonly associated with right-sided and transverse colon tumors. A systematic review in Gut found that new-onset increased bowel frequency in adults over 60 without a clear benign explanation had a positive predictive value for significant colorectal pathology, including advanced adenoma or colorectal cancer, of approximately 6 to 9%. A study from the University of Exeter Primary Care Research Group found that the combination of increased bowel frequency and rectal bleeding in adults over 60 had a positive predictive value for colorectal cancer exceeding 10%. Tell your physician specifically, my bowel frequency has increased from my usual number per day to new number per day over the past number of weeks without any dietary or medication change that explains it. This specific duration-anchored description converts a vague complaint into a clinically actionable observation. Change pattern number 4. Alternating constipation and diarrhoea. A persistent pattern of alternating between constipation, hard, and frequent stools, and diarrhea, loose, frequent stools, that cycles unpredictably, that has been present for 3 or more weeks, and that is new relative to the person's prior bowel habit. The alternating pattern may cycle over days or weeks. Alternating constipation and diarrhea, when caused by colorectal cancer, typically reflects a partial colonic obstruction produced by a growing tumor. As the tumor narrows the colonic lumen, solid-formed stool has difficulty passing through the narrowed segment, producing constipation, the backup of stool behind the partial obstruction. Eventually, the pressure of accumulated stool, combined with the secretory activity of the obstructed segment, drives a looser, more liquid output through the narrowed passage, producing diarrhea. This cycle of constipation and overflow diarrhea around a partial obstruction is one of the most specific physiological signatures of a significant colonic mass. This mechanism is most commonly associated with tumors of the sigmoid colon and descending colon, the portions of the large intestine where the lumen diameter is smallest and where partial obstruction most readily produces the alternating pattern. Irritable bowel syndrome, the most common benign cause of alternating constipation and diarrhea, typically presents in younger adults and has usually been established as a diagnosis before age 60. New-onset alternating bowel habit in an adult over 60 with no prior IBS diagnosis is a different clinical picture, one in which the likelihood of a structural colonic cause is substantially higher. The NICE Cancer Recognition and Referral Guideline identifies new-onset alternating bowel habit in adults over 60 as a symptom warranting urgent 2-week wait colorectal cancer referral, reflecting the clinical evidence that this symptom pattern has a sufficiently high positive predictive value for significant colorectal pathology in this age group to justify the fastest investigation pathway. Research published in Colorectal Disease found that alternating bowel habit was a presenting symptom in approximately 20% of left-sided and sigmoid colorectal cancer cases, with the symptom being more specific for cancer when combined with any rectal bleeding or weight loss. Describe the pattern specifically. I have been experiencing alternating episodes of constipation and diarrhea for a number of weeks. This is a new pattern for me that I have not experienced before. The duration, the novelty relative to prior bowel habit, and the absence of a clear benign explanation are the three elements that determine clinical urgency. Change pattern number 3, increased urgency. The need to rush, a new, persistent sensation of urgency, the sudden, intense need to reach the bathroom immediately, that has become more frequent or more severe than the person's prior experience. The urgency may or may not be accompanied by incontinence. It may resolve after a bowel movement or may persist as a sense of rectal pressure. It represents a change, a new experience of urgency that has developed over weeks and that the person did not experience previously. Rectal urgency, the sudden, irresistible need to defecate, is produced by activation of the defecation reflex at lower rectal fill volumes than normal. In the context of colorectal cancer, this inappropriate early reflex activation is produced by a rectal tumor that physically occupies space in the rectum, reducing the effective reservoir volume of the rectum and triggering the defecation reflex when the rectum is less full than it normally needs to be before signaling the need to empty. This mechanism is specific to rectal tumors arising in the rectum itself, and is one of the reasons that rectal cancer is associated with the most specific and most distressing bowel habit symptoms of all colorectal cancers. The urgency it produces is not the urgency of an irritable bowel or a loose stool. It is the urgency of a rectum whose functional reservoir has been reduced by a mass growing within its wall. Urgency in older adults is frequently attributed, by both patients and physicians, to pelvic floor dysfunction, overactive bladder, or the general changes of aging. These are real and common conditions, but they do not explain new-onset bowel urgency in an adult who has not previously experienced this symptom. New-onset rectal urgency in an adult over 60 is a symptom that gastroenterologists treat as a rectal cancer symptom until a direct examination of the rectum and sigmoid colon excludes this cause. Research published in Diseases of the Colon and Rectum found that new-onset rectal urgency was a presenting symptom in approximately 35% of rectal cancer cases, making it one of the most common presenting symptoms for this cancer subtype. A study in the European Journal of Cancer found that in adults over 60 presenting with new-onset rectal urgency, the proportion with confirmed rectal cancer or high-grade dysplasia on subsequent investigation was significantly higher than would be expected from population prevalence alone. The UK National Bowel Cancer Audit identified delayed investigation of rectal urgency, frequently attributed to benign causes without direct rectal examination, as a significant contributor to advanced stage rectal cancer diagnosis. What to communicate to your physician? I have been experiencing a new, urgent need to reach the toilet quickly for number of weeks. This is different from my previous experience, and I would like my rectum examined. Ask specifically for a digital rectal examination. A simple, rapid clinical assessment that can detect rectal masses within reach of the examining finger, and for referral for flexible sigmoidoscopy or colonoscopy if the symptom persists. Change pattern number 2. Nocturnal bowel movements. Waking to defecate. Being woken from sleep by the need to have a bowel movement, particularly if this is a new experience, occurring more than once per week and persisting for 3 or more weeks. Normal bowel function does not typically require defecation during sleep. The colon's motility is suppressed during sleep and resumes upon waking. Being persistently woken by bowel urgency during the night is therefore a clinically significant departure from normal colonic physiology. The colon's motility follows a circadian rhythm, characterized by mass movements of the colon that occur primarily in the morning upon waking and after meals. During sleep, these mass movements are largely suppressed by the circadian regulation of enteric nervous system activity. When nocturnal bowel urgency occurs, waking the person from sleep, it indicates that the normal circadian suppression of colonic motility has been overridden by a pathological stimulus. In the context of colorectal cancer, nocturnal defecation urgency is produced by tumor-related inflammation and the secretory activity of the tumor driving colonic motility at times when the colon should be quiescent. It is a clinical red flag because functional bowel disorders, irritable bowel syndrome, functional diarrhea, characteristically do not produce nocturnal symptoms. The preservation of normal circadian colonic suppression and functional disorders means that nocturnal bowel urgency is a feature that strongly favors organic, structural, pathology over functional disorder. The clinical significance of nocturnal bowel symptoms in distinguishing organic from functional pathology is well established in gastroenterology, and it is particularly relevant in adults over 60, in whom the organic pathology most likely to produce nocturnal symptoms is colorectal malignancy. The evidence, a clinical review published in the American Journal of Gastroenterology, identified nocturnal defecation as one of the most reliable clinical features distinguishing organic bowel disease from functional bowel disorders, noting that the presence of nocturnal symptoms effectively excludes functional disorder as the primary diagnosis and mandates investigation for structural pathology. Research from Gut found that nocturnal bowel urgency in adults over 60 without a prior diagnosis of inflammatory bowel disease was associated with a positive predictive value for colorectal malignancy of approximately 8%, substantially higher than most individual bowel symptoms in this population. What to communicate to your physician? I have been woken from sleep by the need to have a bowel movement number times per week for the past number of weeks. This is new for me, and I have not experienced it before. The novelty, the frequency, and the sleep disruption component together constitute a clinical description that most gastroenterologists will treat as requiring investigation. Change pattern number 1. Persistent change in bowel habit combined with unexplained fatigue and weight loss. And here is the change pattern that earns the top position on today's list, not because it involves the most dramatic single symptom, but because it involves a combination that is simultaneously the most well-validated clinical warning cluster for colorectal cancer in adults over 60 and the most consistently dismissed by the people experiencing it. Any persistent bowel habit change, increased frequency, looser stools, alternating constipation and diarrhea, urgency, or nocturnal symptoms, combined with 2 constitutional symptoms, unexplained fatigue and unintentional weight loss. The weight loss is unintentional, not explained by dietary change or increased activity. The fatigue is disproportionate, not explained by sleep disruption, depression, or known illness. And the bowel habit change is persistent, not resolving with simple measures, not explained by a clear benign cause. The physiological mechanism in colorectal cancer, this triad of symptoms, bowel habit change, unexplained weight loss, and fatigue, reflects 3 simultaneous consequences of established colorectal cancer. Unexplained weight loss, defined clinically as loss of more than 5% of body weight over 6 months without intentional effort, results in colorectal cancer from the metabolic effects of the tumor on the host. Tumors produce inflammatory cytokines, particularly tumor necrosis factor alpha and interleukin-6, that drive a hypermetabolic state characterized by accelerated protein and fat catabolism, reduced appetite, and impaired nutritional absorption. Cancer-related weight loss. Cachexia is a direct metabolic consequence of tumor presence and frequently predates other symptoms. Unexplained fatigue in colorectal cancer results from two primary mechanisms: iron deficiency anemia from chronic occult blood loss, as the tumor bleeds imperceptibly into the bowel lumen over months, and the cytokine-mediated fatigue of systemic cancer inflammation, which produces the bone-deep, non-restorative exhaustion that characterizes cancer-related fatigue and that is qualitatively different from ordinary tiredness. The bowel habit change reflects the specific colonic location and growth pattern of the tumor, producing the mechanically or physiologically mediated symptom patterns described in previous sections of today's video. Why this combination specifically warrants urgent investigation after 60. The combination of bowel habit change with constitutional symptoms, weight loss, and fatigue is specifically flagged as an urgent cancer investigation trigger in the clinical guidelines of multiple major health authorities. The presence of constitutional symptoms alongside bowel symptoms indicates that the body is experiencing systemic effects of a process, not simply local colonic irritation. And in adults over 60, the most likely explanation for this systemic local symptom combination is a malignancy. The landmark Conteast Research Program, a UK-based primary care cancer diagnosis research initiative, published in the BMJ, found that the combination of unexplained weight loss, fatigue, and changed bowel habit in adults over 60 had a positive predictive value for colorectal cancer of approximately 3 to 15%, depending on the combination of specific symptoms, making it one of the highest-yield cancer symptom clusters in primary care research. Research published in the Lancet Oncology found that the three-symptom combination of bowel habit change, weight loss, and fatigue was present in approximately 40% of colorectal cancer cases at the time of diagnosis, and that in adults whose diagnosis was delayed. This symptom combination had been present and reported to a primary care physician on average 4.7 months before the eventual cancer diagnosis. The most common reason for delayed investigation was attribution of each symptom individually to benign causes: bowel change to IBS, fatigue to depression, weight loss to reduced appetite, without recognizing the combined picture as a cancer warning cluster. The National Cancer Institute has identified this symptom cluster as an indicator warranting accelerated diagnostic pathways, with the recommendation that any adult over 60 presenting with two or more of these symptoms receive urgent colorectal investigation rather than sequential evaluation of each symptom individually. What to communicate to your physician? Present all three symptoms simultaneously. Do not allow them to be evaluated sequentially and individually. Say, I have noticed three things happening together over the past number of weeks. My bowel habits have changed. Specifically, describe the change. I have lost approximately amount of weight without trying to, and I have been experiencing fatigue that is disproportionate to my activity. I am 60+ years old, and I am concerned about colorectal cancer. I would like to be investigated urgently. This specific, combined presentation, delivered with the explicit concern named, is far more likely to produce the urgent investigation pathway the evidence supports than a presentation of each symptom individually spread across multiple appointments. The 5 actions to take. Action 1. Know your personal normal and write it down. The clinical significance of bowel habit change is relative to your personal baseline. What is your normal frequency? Are your stools typically firm, loose, or variable? How urgently do you typically need to reach the bathroom? Write this down today. This baseline is the reference point against which any future change can be precisely measured. Action 2. Apply the 3-week rule. Any bowel habit change that persists for 3 or more weeks without a clear benign explanation warrants a physician conversation. Not 6 weeks, not 3 months, 3 weeks. The research on optimal cancer diagnostic timelines consistently identifies 3 weeks of persistent unexplained symptom change as the threshold that justifies urgent evaluation in adults over 60. Action 3. Present symptoms in combination, not sequentially. If you have multiple symptoms occurring together, bowel change, fatigue, weight loss, present them together at a single appointment. The combined clinical picture of a symptom cluster is more diagnostically powerful than each symptom evaluated in isolation. One appointment, all symptoms, explicit cancer concern stated clearly. Action 4. Ask specifically for colorectal cancer investigation if you are concerned. It is appropriate to name your concern explicitly. Say the words, "I am concerned about colorectal cancer and I would like to be appropriately investigated." This is not alarmism. It is informed patient advocacy. Research on diagnostic delay consistently identifies failure to explicitly name the cancer concern as a factor in delayed investigation. Action 5. Follow up if investigation is not offered promptly. If your bowel habit change is persistent, unexplained, and has been present for 3 or more weeks, and you are sent away without a clear investigation plan, follow up. Ask when the investigation will occur. Ask what the waiting time is. Ask whether urgent 2-week wait referral criteria apply to your situation. Persistent, informed patient advocacy is one of the most consistent factors associated with earlier colorectal cancer diagnosis in the research literature. The most common theme in the stories of adults who have been diagnosed with colorectal cancer at a late stage is not dramatic ignorance. It is reasonable dismissal. They noticed something. They thought about it. They attributed it to something benign. They waited to see if it would resolve. And by the time they stopped waiting, the disease that had been speaking quietly through their bowel habits for months had reached the stage where treatment options were limited and outcomes were dramatically worse. This is not a failure of intelligence or attentiveness. It is a failure of knowledge, specifically the knowledge of which bowel habit changes warrant urgent investigation, how long to wait before acting, and how to communicate symptoms to a physician in terms that generate an urgent response rather than a wait-and-see approach. You now have that knowledge. You know the 5 change patterns. You know the 3-week rule. You know the importance of presenting symptoms in combination. You know how to name your concern explicitly. And you know that the research consistently shows that early investigation, prompted by symptom awareness and prompt action, is the most powerful determinant of colorectal cancer outcome available to adults over 60. The most important message of this entire video is the simplest one. When something changes and it stays changed, and you do not have a clear explanation for why, speak to your physician. Today, leave a comment with your age and whether any of the 5 patterns in today's video describes something you have been experiencing and not mentioning. Be honest. Your comment may be the prompt that someone else in this community needs to make the call they have been postponing. If this video gave you something genuinely important, please hit like. Share it with someone over 60 who has been telling themselves that a bowel habit change is nothing to worry about. It may be nothing, but it deserves to be evaluated, not dismissed. Subscribe for weekly research-backed content on cancer early detection, bowel health, and the clinical information adults over 60 deserve to have clearly communicated. Your bowel habits are speaking. Know their language. Listen promptly. Act immediately.